Yes, Dr. Ashish. Start with the new player. The debut player should get the chance. Okay. So,
thank you so much.
yes, Dr. Ashish.
Good evening, sir. Today's session was very wonderful. So, very informative. I have asked already 4-5 questions regarding is that is tolerable, is it well stored, or which is more beneficial, chiropractic or physical therapy, and what are the different types of treatment as according to the disc bulge, according to profusion, extrusion, anti-prescription. So according to that, whatever you explain, showing this only, my questions are clear, all the concepts are clear, and I come to know how to treat, what are the positions, how to maintain the position, how to correct, especially through postures, the patient who are suffering from the ligament strain and strain also. In that you have you present about especially musculosis pulposus amyloidosis fibrosis, vitamin strain will be there, then a big chunk of strain. So for that, you have to go for the focal correction, especially in prone position. You have to go for the flexion exercise. At which time we have to go for the extension position, extension exercise. So according to me, that session was very wonderful, and of course now I cleared with each and every concept, and I got all the answers of my questions.
And especially if the posterior laxity is there, annulus fibrosis, flexion traction. So if laxity is not there, no problem. Neutral traction or extension traction. Yes. Great to hear that. Dr. Paramita?
Yes, good evening, sir.
You have become like one guest of honor. Huh?
No, I'm the old member of AOMPT.
Yeah, but you are not to be seen only. Huh? You are attending the courses, but you come at a time when I am demonstrating. At the interaction, suddenly like I interact, you are not there. Or you are there that time I am demonstrating.
Actually, Priyadarshini is having online exams half yearly, so she needs my phone and she takes my phone away. So that's why I don't have to. Yeah.
Understandable, no problem. Even Ritu actually makes her son attend the classes in her phone only. Okay.
Yeah.
Sometimes it's good to watch the children also. Huh? Because whatever you do, we don't know what apps, what prompt, and what other children, okay, what they show, okay. Teacher will be occupied with the PowerPoint slide, and in the Zoom, the moment slide is loaded, we cannot see the participants. The participant screens visually, we cannot see. Only participant list will be seen if I swipe the screen. Okay. So that's the major thing, concern. The teacher won't know what is going on in the background. Okay? And they all can look at each other. If two mischievous students, they are showing something here and there like that, this innocent one also will be like, oh, okay, this also is there. Or they get distracted. It's very tough for them to learn all these things. But even if you are sitting and attending also, it's tough. You cannot alert the teacher. You cannot tell anything. I don't know how you can manage. It's tough. No? It's very...
She will be roaming around. She will be getting up. That's why. Her exams will be over in this week, I think. So it was a very, very, very different type of webinar I have seen today, because usually we feel that if disc problem is there, then traction should be given in supine position, which we usually do by mistake. And so the mistakes have been actually, if you go through the video again, we can actually rectify our treatment, which we had been doing.
There is one more thing which I want to add. there is something called as treatment-based classification. Okay, there is subgrouping of low back pain. In that, they got a traction subgroup. What is the criteria for traction? And they saw that there's a clinical prediction rule for responders for traction, okay, lumbar traction. So in that, the primarily neurological deficit. So there has to be radiculopathy. And secondarily, there should not be directional preference. That means flexion or extension. Nothing is centralizing the symptoms. Then you can give traction. So this is what they have mentioned. Only these two. Okay. You can modify that into, yes, radiculopathy, but degenerative radiculopathy. Okay. Directional preference will not be there when there is instability or extrusion. Okay. Constant symptoms and things. So sometimes the extrusion, which is a resolved extrusion, you can give, but not in the supine fowler. Say, I would rather prefer the same prone and then auto traction rather than the supine fowler position and then giving the traction. Okay? And relief with the manual traction. So they tell that leg you can pull, although Ritu ma'am will not like leg pulling. She likes holding hands. But leg pulling, if you do that leg manual traction and if the subject is having relief, you can give mechanical traction. That is the third criteria.
Pulling in supine or prone? Supine or prone?
That literature mentions that supine only. Okay, that articles they mention as supine only. But what I would advise is best is prone. Okay.
Prone.
If the foramen encroachment is more like stenosis, and because of which the extension is creating a peripheralization, then use a pillow under or the wedge under the abdomen, create the flexion. But give that flexion, in the prone position only, create the flexion and then give the traction. That should be the flexibility there. So that gives a various options. You can create the spine to become in extension or flexion, okay, or rotation.
Yes.
Rotation is another technique which can be useful for disc because annulus fibrosis. I was telling you in the early stages when sitting and then bulges there means tell the patient that do some mid-range rotations because annulus fibrosis, torsional forces they resist first, then only stretch, direct stretch, tensile force. So sometimes you might get relief of symptoms. Rotation will bring back the nutrition to the nucleus pulposus from the end plate, the water. So that way also it's important. But degeneration, rotation may not help. Okay. Wow. What ma'am? I'm not unmuting. Yeah, unmuted.
To me? I'm unmuted only.
Yeah. Yes, Darshana.
Yes, sir. So I think a very important lecture today because it has broken all the conventional myths. Understanding the mechanics of this prolapse, how gravity affects. So supine will increase the prolapse or prone position will push the disc inside. So all these little mechanics, if we understand, it definitely gives us a different perspective of treatment and a more clear perspective rather. I think two things which I found really interesting is the functional corrective positions, what you showed, just the posture corrections, what you showed, start from cervical and go to the lumbar and the pelvic corrections, and then maintaining it to build up the endurance of the muscles. So that is something very definitely
Like
good.
we start from cervical spine, end with the cervical spine in the beginning. Later we start with lumbar. Keep the lumbar held with the pelvis.
Yes.
Come back and end in the pelvis. Okay, for the endurance.
Because I was just doing it for myself. I usually have pain when I sit like slouched. Okay, I cannot sit for more than 3-4 minutes, But then when you're doing it, when you're teaching it, I started doing it myself, and I think it makes a difference. There's no pain. I can sit at least at 5 minutes, 10 minutes. It was that endurance has improved definitely. Otherwise, I had excruciating pain when I was sitting slouched. So in like comparison to that, I'm feeling better. That is one thing. And of course, the prone traction, what you have shown, is something auto traction. That is something extraordinary new for me. And I think it makes sense to give traction in that way instead of what we were doing conventionally. So yeah, I found today's lecture very interesting and very informative.
In fact, if I had had the traction unit, I might have shown in that prone traction only giving the traction. Because the belt for the pelvis is the same, okay? And the counter force has to be given. That is anyway, patient is holding the table, or the upper trunk can be again that same another strap can come proximally. So, and then traction, because celiac treatments, they use like this. They have assistants holding both the hands or the scapula, okay, the trunk traction. Another assistant pulling both the legs, okay? And then celiacs is giving the spinal manipulations and sometimes the thrust manipulation. So with the traction and rotation, which is a loose body reduction technique, distraction with rotation. Same thing he used it for disc reduction. And he said that more than 500 cases they got this material reduced. Maybe they must be only protrusion. They cannot be more than that.
And so also, I mean, we've seen patients, I mean, you were mentioning this Superman positions and those things, you know, which we normally see patients go for yoga classes without understanding actually what is the problem. And they come back with like, you know,
What
excuses.
happens with yoga is one is the range. Okay? They do too much of extreme ranges of postures. Another thing is the breathing awareness. The instructors tell them that breathe during one movement and breathe during another movement. If you are holding the position means don't hold the breath. Keep breathing in that position. This is what they tell. But these people, what they do is they hold the breath. Pressure becomes more. The intra-abdominal pressure. Suddenly they leave the breath. Okay? Then that is the situation, especially like positions like
Especially in Surya Namaskar when we are Cobra position.
Forward bending and then arching, all that. Okay, everything will involve. Even another is distraction. Sometimes in yoga, what happens in the yoga classes? Everybody is doing. So you might do slowly and you look at others. Okay. The others will come third repetition, fourth repetition, fifth time you will come back. Okay. Like as if you are doing 5 times.
Yeah, but many times these wrong, I mean, what conceptions they have that aggravates the symptoms. But now, like we mechanically know what's happening, we can definitely guide them in the right way.
But one thing is yoga is beneficial. There's nothing wrong. But like for example, Dhanurasana and all, end range extension and then holding the leg and all. It is really you have to see whether physically and physiologically the patient can do it. Okay. Otherwise, it will create a muscle catch, strain of the muscle because of overactivity. And even that active extension effort also intradiscal again pressure will increase. These are all things. But the same if you see that prone on elbow, prone on hands, and all these are all like Dhanurasana. So that is very the same as the yoga. So it need not be that. Yoga means it aggravates. It's only some of the postures for some people. When it is not properly done, then it becomes. But in that situation also, it's a good question because we have to ensure that we recover the patient. We should also make them to have the stability to do the yoga. Okay. If the patient tells that yes, I want to continue yoga. So, but you should also be telling that which ones to avoid and which ones better now. Same like the gym, same like that swimming, any kind of spine activities like yoga. Travel, if sometimes you see that sitting and then axial compression, okay? So sitting, flexion, posterior annulus is stretched and compression. There will be a bulge. Okay. But after that, immediately correcting means sharp pain will come. This walk with the straight spine. After that, you correct means it will be fully correcting. Okay. Because the annulus fibrosis, which was actually bulging, which was getting pinched, was reduced by rotations and also rehydration of nucleus fibrosis by walking. Any kind of another thing is the central mechanism is the new central pattern generators. In the spinal level, there is a peripheral memory. What are the lower extremity activities? Part of it, what I demonstrated as cycling, is utilizing the central pattern generators. Okay? Even if the patient, you are making them to do walking on the wall, okay? The same technique which quite well before it showed. I think for the ankle plantar fascia, what I okay? So this again is a central pattern generator. Okay? So that means the patient is not able to stand and then walk. You are making them to do in supine, but supine I don't advise. You better do prone. Obese patient, remember that you have to take care that prone they cannot, they might feel breathless. So in that situation, you will create relief points. Keep another soft pillow so that abdomen is free of pressure.
Thank you, sir.
Yes. Ritu ma'am? Yes, ma'am.
Yes, sir.
Yes.
So there is some problem with the internet, so the screen was stuck.
Yeah.
Yeah. Yes, sir. Thank you
Okay.
so much. Very nice section that many more things are now more clear now. How we can differentiate between the dysfunction with the nucleus pulposus or annular fiber, because there was some myths in our mind that the patient with the come with the disc bulge, we just think about the bulging, but we were not thinking about the what is the cause of this bulging. Either the nucleus is the cause, either the annulus fibers are the cause. So today you have shown in a step by step the things which you were telling, how we can check, and the main thing which you have shown that how we can give the traction and all that in the prone position or supine according to the dysfunction where is it's needed, because we always think that we can keep the patient in a comfortable position supine, it's okay, but now you have shown that we can treat also in a prone position or in the quadrupod position, cat and camel position, everything. I think it will change our direction to treat the disc bulge patient previously, which we were not thinking about.
Most of the time, present scenario, the disc bulge patients don't come to us when they have disc bulge. They come to us only they have radiculopathy.
Yeah, right.
So that is the reason why we are facing more prevalence of radiculopathy than the
Exactly.
all of us
Right.
might have, and we might just ignore, just keep
Right.
moving.
So I think very nice that that was the section which you were showing the correction of upper cervical and scapular retraction with the lumbar. That was very, I think, very new. I have never seen and I have
But
never.
what I wanted you to notice is earlier in the quadruped position, when Gautam, I was asking him to dissociate lumbar and pelvis, he was not at all able to do it. I got frustrated one day when I was demonstrating live. But today I am telling, okay, he's able to do that, the 4 segments. Okay. When he was sitting also, pelvis, lumbar spine, scapula, neck, okay. He's doing, okay. So maybe his motor control is also improving. What, Ritu ma'am?
Yes, sir. Very nice, sir. Actually, I was thinking that the patient, they have with the disc bulge, some patient feel they are after walking for some times, they feel starting heaviness in their legs. So now you have correctly said that this is the cause of radiculopathy, which were causing because of the disc bulge. The patient is
Sometimes
feeling.
heaviness can be disc bulge compressing the dura mater and the arachnoid membrane. Okay. CSF, if there is a disturbance in the flow, it will increase the venous stasis. Okay. That is why we check the intradiscal pressure by jugular vein pressure. Nafziger said. So venous and CSF flow, it's interdependent. You block one, the other one will become overloaded. Okay. So CSF will be blocked because of the disc bulge, the distribution disturbance. So the venous overload, legs will be felt as heaviness. If it is radiculopathy, it will be shooting pain, not a heaviness. Okay? So you should see the radiating pain, shooting pain with the heaviness. It may be a combination of nerve root and venous.
Right.
Claudication is vascular or neurogenic. If you elevate the leg, if the relief is there, it is vascular claudication. If you are that elevation will aggravate the symptom because SLR questions. Elevation is neural. So, yes, Ritma.
Yes, sir. Very clear now that how we can differentiate between the vascular, arterial and the radiculopathy also. That there is one thing is more clear now, that everything, whatever you are telling, that we are adding all these points in the sequence of checking the disc bulge, then radiculopathy, then vascular, arterial, everything will be adding for the betterment for the patient, how we can treat this type of patient. So it will be now easy to treat this type of patient. Sorry, sir. Sorry for disturbance. So it's very nice and very clear. I think I have to see this, the pathomechanics of part today's session. I have missed many things. So I will see it again. Then I will make a note. Then more clarity will come according to it. But,
Any diagrams you made?
no, sir. Actually, sir, Actually, sir, my eyes are not in a good condition. I went to doctors, and he's saying the fundus of the eye is going weak, so you cannot see more mobile. Don't concentrate on more screen. So I am taking away the phone from me. I'm not using from morning only. I am using for your classes from morning to 4 o'clock. I am not using my phone, not seeing the screen. So nothing I am going to making the drawings also is now not allowed by the doctor. So after the treatment, I will definitely make all the diagrams. And then I will start that use the
Diagram
spec.
making is,
Yes, sir.
diagram making is not very tough. You can easily make it.
No, sir.
Screen looking only problem.
No, but sir, eyes are not in a good condition. I am feeling very much pain in my eyes. So much stress coming. So that's why I'm not concentrating on the screen also. The dryness is coming in the eye. So I think I have to start again the cranial-neural manual therapy for my eyes. For the optic nerves, I will start trying on myself.
You are doing that and you are feeling better. Now suddenly again.
Whatever the course
I
you
know when did
launch
you
now,
stop?
I'm saying whatever the course you launch now, all dysfunction comes in myself. I feel in myself. That's why my eyes are going in a problem. The neuromanual therapy I have needed. Right, sir. I will present my case study for the cranio-neuromanual therapy for optic nerves when I will meet myself. Right, sir. Thank you, sir. Thank you so much. Very nice session of disc bulge. Over to you, sir.
So we are ready to close the session today, right?
Yes, sir.
The